So my name is Kim. You don't know me either. I'm the Global Health Fellow. I'm a family medicine doctor who works at the center. But I am introducing you now to our speaker, who is Mould-Millman. Is that right? Okay, good. Dr. Millman did a duo fellowship at Emory, both in EMS and in global health. After which, and throughout, he worked in several parts of Africa, including Ghana, Kenya, and South Africa, working on pre-hospital emergency services, which he'll be talking about today. That's it.
Thank you.
Thank you for having me.
Can everyone hear me okay? All right, very good. Well, thank you all for being here. Please eat, and my stomach will be grumbling as I watch you eat. Good. Just so I can have a feel for who's in the audience, how many students do we have, medical, otherwise? Okay, the majority. And then faculty, fellows, faculty, non-sort of medical staff, other research. May I ask for your interest or your background?
Global missions.
I see. I see. Okay, wonderful.
Oh, I'm a volunteer faculty on the Global Health Program.
Oh, wonderful. Okay, good. Well, welcome everybody. And I think we have about an hour. Now, this is a topic that's near and dear to my heart, so I could probably ramble on for hours about this, but I won't. So what I hope to do today is to kind of walk a fine line between giving you a very sort of broad overview of some of the issues around emergency care systems in sub-Saharan Africa, understanding that sub-Saharan Africa is a large, very, very heterogeneous place with incredibly diverse populations, cultures, systems. So you'll have to forgive me for that. There's not a simpler way to really do that. I can't go through country by country. And then on the other side, what I'm going to do is I'm going to try and sort of point out what the developments or advances are. So this won't be just a talk about the issues, but what some of the solutions are. And I think some of them are quite innovative. They may not seem innovative from an American or North American perspective, but when you understand what the issues are, you'll see why some of these sort of basic things are really innovative in the sub-Saharan setting. So I spend quite a lot of time, several weeks to months a year on the ground, doing work. While my focus is mostly pre-hospital emergency care systems, and I'll explain to you a little bit more about what that is. I spend a lot of time also doing in-hospital teaching and training and systems development and working with ministries of health, in several different countries. So, all right. So with that long intro, let's see if I can figure it out. So I have no real conflicts. I do have some small grants that sort of complement the work I do. So why should you care? I suspect that we would have quite a number of students in this, in the audience. So I threw this on purposefully. So recently there was a University of Michigan student, med student, who was in South Africa, for a couple of weeks, and was a victim, died in a road traffic accident or collision. And this is not an uncommon event. So for those of you, I'm preaching to a choir, you are all by definition sort of interested in global health, probably will plan or have been somewhere overseas at some point, most likely to a low to middle income country. An enhanced emergency care system could be to your direct benefit. Okay, hopefully you'll never need it. And then I think we're probably all have a little bit of Ebola fatigue going on right now. But I think another very, very contemporaneous reason why understanding the infrastructure around emergency care systems is probably important to us. So we're going to do 4 things today. We're going to talk about the burden of disease in sub-Saharan Africa, and I'm going to spend a few minutes talking about the burden of acute disease within that. We're going to discuss challenges. I'm going to sort of explain to you what the 3-tier model of integrated emergency care is in sub-Saharan Africa, and we're going to talk about some innovative approaches to building those 3 tiers of care. So I'm moving. All right. Some of you might recognize the picture on the right. It was in the front page. It was actually won a couple of awards, and it was on the front page of Time magazine a couple of years ago. This is when there was a lot of, sort of at the peak of the HIV/AIDS, epidemic, when there was a lot of funding, a lot of interest. And I think HIV/AIDS has been a great champion for, the burden of disease in sub-Saharan Africa across all non-specific to emergency care. So, so what exactly is the burden of disease? So, if you go to any of our leading sort of global health agencies, sort of the consensus is something like this, and it varies from agency to agency, region to region. But top causes of death listed over here, those in red are those that have, I think, particular significance to emergency care. Things like HIV, malaria, respiratory infections all go through some sort of acute phase, and there's a possibility of sepsis and death as a result from that. Same with cardiovascular disease, TB, heart attacks, road traffic injuries. Sort of in the last, decade, there's been a lot of talk of the dual or the double burden of disease, and I think this has been, this composes of communicable diseases, HIV, things like Ebola, lower respiratory infections, meningitis, and then non-communicable diseases. And I think non-communicable diseases deserve sort of special mention, particularly because their prevalence and the burden of those are growing in Africa. Why? Because of urbanization. We see a trend, a shift in populations moving from more rural areas to more suburban and urban areas, and with that comes a change in lifestyle that may be a little more sedentary, a little more unhealthy, and as a consequence, you have chronic diseases. And especially now with HIV, survival in HIV, people are growing older. There's now a change, a slight shift in focus from HIV to looking at chronic diseases in HIV. Because these folks are now aging and developing cardiovascular disease, diabetes, and so on. I don't know how many of you have ever heard of this software, worldmapper.org. So it's a fun way to sort of depict an issue graphically, and I'll walk you through it. So across the world, we know that low to middle income countries have disproportionately worse outcomes. If you compare the outcomes in sub-Saharan Africa to other lower income countries, they're even worse. And hopefully this will give you a flavor of that. So what Worldmapper does is it presents each territory or region as a size that reflects the prevalence or the incidence of a certain variable. So in this case, population. So Africa is about 1.1 billion people. The continent, I think, is about 7.2 billion people. So you can kind of see that represented, 1 in 7. So this shows global poverty. You can see that despite the population, the burden of global poverty is a lot larger in Africa. And of course, you'll see that India and East Asia, specifically China, also carry a significant proportion of the global burden of disease. Tuberculosis, you see that Africa swells even more. Malaria, these are deaths from malaria. Now, granted, 95% of all malaria cases are in sub-Saharan Africa, so I think this is fairly proportionate. In terms of disasters, Africa actually doesn't have its share of, I think it has a fairly small share of global disasters. Nowhere as many as sort of China, India. But if you look at those killed by disasters, it is clearly a disproportionate amount. If you look at the total births annually, if you look at the maternal mortality, right, that's a huge difference. Total births, maternal mortality. Clearly a huge disproportionate outcome. Again, the total births and the under 5 mortality. Okay. What about road vehicles? So Europe and sort of the Americas have their large share. Africa does not have very many vehicles on the road. However, when we look at road deaths, again, a huge disproportionate difference. And I think the burden of disease from road traffic collisions deserves special mention. One, because it's projected to sort of rise, in frequency and prevalence over the next decade and a half. And two, because actually, aside from HIV, no other condition other than trauma, has been a better poster child for the need for emergency care in sub-Saharan Africa. So those of us who sort of go out and advocate to build emergency care systems, we often fall back to trauma as a nice reason or rationale to build those systems. So I've given you a very broad overview of the general the causes of morbidity and mortality in sub-Saharan Africa. What about the subset of emergency conditions? Well, it turns out that those data are actually unknown. Nobody has been collecting them. Why? Because there hasn't been the focused interest or the recognition that maybe it's important for us to know what specifically is killing people in an acute and an emergency phase. So how do you solve this problem? Well, you go to an agency like AFEM, which is a fairly young organization, about 8 years old, and is the African Federation for Emergency Medicine. There's now a leading advocacy group that represents emergency providers and professional societies across the continent. And so I'm a very active member and a leader in AFEM. And so we write, right? So you gather everybody together and we write. We say, here's what we think, the priorities need to be. And so my focus was pre-hospital research. So we wrote, we said, look, we think there needs to be more focus, there needs to be more research, there needs to be more epidemiology, there needs to be more outcomes-based science. And we gather people, we gather experts, we bring them from around the continent, we sit them down and we say, where there is no data, well, let's make some, let's use expert consensus and try and make some recommendations to move the field forward. So we did that. There have been 2 of these in 2011 and 2013. And as a result, members and other people interested in emergency care around the continent listen, and they start doing research and they start publishing. So one model we built to help that is we said, look, one way to standardize this is let's measure to help build the data around the epidemiology of emergency disease. Let's look at 2 things. Let's track sentinel conditions and signal functions. And a sentinel condition could be alt mental status, chest pain, in this case, shock. And signal functions are all the important things, the critical things that you should do in recognition of one of those conditions. And this has been a nice model to help, folks think about how they can start collecting data, that's standardized, to other countries. So people have been publishing, they've been doing this work, and these are all data from the last year to year and a half. So in Uganda, for example, the folks in one of the emergency centers, start publishing and they start reporting the trends of, diseases they see in their acute and emergency centers. So malaria, pneumonia, and other infectious complaints at the top of their list in Uganda. Trauma, let's see if I can work this. All right, so trauma is the next major category. And then down below, we have GI complaints, neurologic, dehydration, cardiovascular complaints, and so on. So the data is growing. Now this is just one country, one site, but it's better than, it's better than 2, 3, 4 years ago where there was no data really. So Botswana, Kessler and his group published some great data as well, and very similar. You can see down here, infections, trauma, obstetric and gynecological emergencies. So it's a little difficult to read. Non-communicable diseases, GI disorders, anemia, probably from malaria. In Lusaka, Zambia, very recently, actually, the investigators looked specifically at all cases of trauma. What was the cause of trauma and what were the outcomes? And you'll see the arrow down here depicts the road traffic accidents, or we don't really use that term anymore. It's really road traffic collisions. Have a large contributor. Okay, and also I think we'd be remiss if we didn't talk about the contribution of intentional injuries. Okay, so the data is growing, and this is helpful. This is helpful to go to your Ministry of Health and say, hey, look at what we're seeing. We need more trauma resources, or we need help, managing acute, obstetric complications and emergencies. So now to tie back World Health Organizations, what the large causes of death are. The research that's been done in the last year or two is very helpful to start unpacking these conditions. Well, what is it about lower respiratory infections, or that kills people? What cases of diarrheal diseases are we seeing? Are they pediatric? Are they adult? What are the outcomes of those patients? So I think the data is growing, and this in itself is really innovative for Africa. We take this for granted, sort of a lot of epidemiological work in the U.S., but this is difficult to do when you don't have very robust data collection systems. And you have folks who are caring for hundreds of patients and don't have time, to go home or go for a meal. I mean, stuff like this takes a lot of resources and dedication. So I think it deserves special attention. Now, yes.
So in that last slide, you have that 28% of the deaths are HIV, and then you have a list of all those symptom-related diagnoses. Do you have a sense of, if you wrote this out by HIV versus not HIV, would they be very different?
Good question. I'm not sure for these. I know in West Africa, for example, I know the prevalence of HIV is a little bit lower. Yes, you would see a bit of a difference. The sort of conditions that HIV patients present with nowadays, especially in West Africa, where more people are on ARVs, tend to be sort of more terminal, more chronic wasting, so more subacute. So I think, but things like, complications from tuberculosis and sepsis that present in the acute setting, may make it on this list. So I'm not, that would be a little too, I don't think I know enough about the specific data in HIV to be able to answer that accurately.
But it would make you have to consider whether you want to put your resources into the causes of death or the causes of acute presentation.
Agreed. Yeah. So a lot of outcomes-based research is extremely difficult to do, looking at especially mortality, just because of you have to track patients through the hospital, call them back in 30 days, And so most of the studies coming out are sort of pick the slightly easier routes, which is how do patients do when they leave the emergency department or center? Do they get admitted? Do they go home? Do they die? So there's some limited data that's starting to evolve. And again, all this is just in the last sort of year and a half, 2 years. Now, people have been doing this, of course, for decades, but in emergency or acute settings, this is fairly new. So you can look at all this very large burden of disease, and you can be very dismayed, and it's very disheartening. Or you can think of it as an opportunity, to help build and improve systems and hopefully save lives. So we'll transition into the next phase of the talk, which is we'll talk a little bit more specifically about the challenges in sub-Saharan Africa around these emergency care systems. And again, understanding that sub-Saharan Africa is a very heterogeneous, wildly different place based on where you are. So you'll forgive me for making some very, very, some large assumptions, and I'll really simplify the condition. But I think it's important for me to sort of point out that poverty is probably one of the most significant sort of fundamental underlying issues. Some recent studies have shown that if you give a family cash, just a little bit of money, it turns out their health outcomes are slightly improved. Okay, so over 40% of people living in sub-Saharan Africa live in absolute poverty, and that's defined, I think, around 75 cents a day. Okay, so preventative care, access to medications, access to routine care, prenatal care, things that are often forgotten because of real-life circumstances. So what are the issues specific to emergency sort of medicine? Well, there's quite a lot. There are quite a lot of things. Even in the U.S. and in a lot of developed settings, emergency medicine and emergency care is a fairly new specialty. There are several countries in Europe that still don't recognize emergency medicine as a specialty, but they still provide emergency care. It's just not its own sort of house, so to speak. And so we see this in many, many settings across sub-Saharan Africa, most of which are, former colonial states and have that old mentality. So it's very common to go down to an emergency or an accident, an emergency unit or an emergency center, and it's the middle of the night. The only person who's there is the junior-most physician in the house. It's like where you are relegated to go die if you're a young, struggling physician. Because it's, quite frankly, it's not valued in a lot of settings, and I hear this from collaborators from all over the continent. Furthermore, in these emergency centers, what you find is they're split up, like it was in the US, 15 years ago, and it still is in some settings, where trauma has its own sort of section of the emergency center, medicine does, pediatrics may, and that sort of really silos and fragments the care, actually makes it more challenging to provide seamless sort of integrated care in a very coordinated way. They're very poor models of emergency care in Africa. And this is important because governments, institutions that may be interested may be really perplexed as to, well, how do I solve this problem? Can you just give me a tool that I can apply in my setting? And they don't quite exist, so we're working on them. There's a lack of professionalization. And that's a significant issue because you need champions in the field to go out and advocate for funding and for more resources, both at an institutional level and a government level. And if you don't have, an emergency care society, for example, it makes this very challenging. So they're starting to pop up. There are now 4 or 5 emergency medicine societies, professional societies, in East and West Africa and Southern Africa. Not many, but again, that's all in the last 2-3 years. I think I missed. And then there are other issues, the lack of pre-hospital transport and care, which is either ambulance-based systems or motorcycle-based systems. In hospital, there's a lack of personnel, and not just in the emergency center, but sort of across these healthcare systems. And then a recent phenomenon where we're beginning to sort of discover, and that requires more attention, is in places and institutions that are training emergency care providers, like nurses, for example, what we're finding is that the hospital administration says, oh, wow, they're really good at what they do, and they have a very wide skill set. Well, let's take them up to the ICU, or let's take them up to the OR to help. Because again, so that emergency medicine isn't inherently valued. So hopefully this will change, and there's been a lot of advocacy from some of the professional societies against practices like that. And then there are limited career development opportunities. We find that there's a large cadre in many sort of sub-Saharan settings of young professionals just out of residency, training or housemanship, 2-3 years out, and all of a sudden they get scooped up to be administrators and get scooped up into the Ministry of Health, and then there's this huge gap of providers. Who can do research and who can train their, younger colleagues and med students. And emergency care, that's, I think, furthest behind all the other specialties. And there's supply chain issues, of course, of medications and non-consumable products. So I'll paint you a picture. And again, I apologize, this is very simplified, and I'm stereotyping heavily. But again, from country to country, I'm still yet to meet somebody from a sub-Saharan African setting about a trauma case who will tell me a very, very different story. This is a pretty common scenario. I'm sure most of you have probably heard of or experienced it, but we'll sort of live through it just to, because I think this really will help contextualize the subsequent points I make. So poverty, I wouldn't say anything else. Is a pretty common sort of scene driving around, in many countries in sub-Saharan Africa. For whatever reason, bad roads, overspeeding, alcohol intoxication, big problem. Some places where they breathalyze drivers randomly. Ghana, Uganda, South Africa, up to about 1/3 of commercial truck drivers are heavily intoxicated on the streets, carrying passengers. So that minivan over there, probably carrying about 15, 20 people all crammed in, no seatbelts. It's expensive. You take out all the old seats and you try and cram as many more seats as you can to make money to survive. Well, so what happens? So there's a road traffic collision. Bystanders, very well intentioned, sort of respond, try and yank people out of the vehicles, toss them into oncoming taxis or private cars, and these good Samaritans rush these folks to the nearest health facility. So in Ghana, for example, the district hospital is a frequent sort of first point of entry. Sub-district hospitals are usually very small clinics, and most people want to sort of transport you there. So fine, so you hit a sub-district hospital. So what do you have there when you arrive? Well, you know, most of these, you know, will have some basic, very basic resuscitation area, bag of fluids, maybe some splinting supplies, and a sort of an undifferentiated physician, you know, who's most likely, you know, well-versed in internal medicine, a little bit of orthopedics, you know, maybe some pediatrics, a little bit of OB/GYN, but no real sort of trauma-specific, heavy trauma training or emergency care training. You know, so they do their best, try and stabilize the patient, maybe a splint, maybe an IV. You know, usually what happens is these, you know, patients will spend a few hours, and this is reports from over a dozen different countries, all say the same thing. The in-hospital delay at the first point of entry is significant. We don't know why. We know we sort of understand very informal reasons why, but this hasn't been very heavily studied. I think the obstetrics and gynecology literature from the 3 delays model has characterized this problem nicely. In the emergency care literature, we have not. So anyway, so there are delays, and ultimately, the patient, it's recognized that the patient needs a higher level of care. So what happens? If you're lucky, your hospital has, you know, maybe an ambulance or a vehicle with a driver who can transport the patient. Most of the time, you know, they do not, and you wind up going by taxi or private vehicle, and the patient is left with and their family are left with the problem of having to pay for this. Okay, so real problems. How do you solve such a problem? Real problems. If you're lucky, you know, you can make it to a regional referral center, which may be, you know, minutes to hours away over rough terrain. So here we are now about 12 hours, you know, to 24 hours after an incident. You've maybe received some very, very basic stabilization, unlikely a fast scan, you know, probably no assessment of any internal bleeding. And so finally you make it to a regional referral center that, you know, has, you know, maybe a neurosurgeon or an orthopedist in-house, maybe a trauma team, an X-ray machine maybe, no CT scan. I think that would be, you know, we'd be pushing it if we asked for a CT scan. So the patient, you know, receives their stabilization, and you know, and here we are 12 hours later, and a lot of patients don't do well. So in a study from Ghana recently, where they looked at all the outcomes of patients brought to this emergency department, and they have emergency medicine residents and a few attendings, and their mortality for patients triaged in as red, which is sort of the highest acuity, was 35% in 24 hours. To receive a red score, it doesn't take much. It takes a moderate mechanism of injury, and this is South Africa triage, a moderate mechanism of injury, tachycardia in the 120s, slight tachypnea. I mean, you know, obviously sick patients, but the mortality is high.
What is it here? 5%, 10%?
Oh, lower. In the order of 1-2% from critically injured patients. Yeah. So I don't want to, you know, sort of, I've speculated some, and I've given you some unstudied reasons why the mortality may be low. And again, there isn't data to back all of this up. So I apologize. Some of this is, you know, it's not very evidence-based, but there isn't data. So the story will ring very similarly if I tell you about infectious diseases, emergency obstetric care, where there's actually, and one of the big issues in emergency obstetric care is the initial delay in seeking care. And there's actually quite a large delay as well when patients reach the primary facility and for some reason they're not referred out appropriately. Ischemic diseases. And then in the US, this isn't a significant problem, but the burden of disease from patients, especially the mortality, patients who die trying to get from one small hospital to a larger hospital is dramatic. When pre-hospital emergency care and transport systems are built, these systems, you know, initially think they're going to respond to primary responses, which is, you know, incidents in the field, in the home, on the street. And actually about 70-80% of their resources get consumed, sucked into doing these emergency referrals from one hospital to another every day. And published reports from several countries all say the same thing. So there's a large sort of what I think of a hidden burden of disease within healthcare systems. So what's the solution? And maybe before I sort of branch into the next half of the talk, I don't know if there are any questions, concerns, anybody have different experiences? So I like the term Afrocentric. It's been used to describe how trauma care systems should be built in African settings to be locally appropriate, sustainable, engage in the community and so on. And we'll talk about that. So there's some overarching principles to how one builds an Afrocentric emergency care system. Clearly, there are several critical components. There needs to be training. You need the human resources to do this. You need some sort of infrastructure. And we're not saying build and buy new infrastructure, but think about how you're going to use what you have to work for you. There has to be a change in the medical culture where sort of the day one out of medical school, houseman isn't sent to the ER to be there on their own all night long. There has to be a change in the culture. And I think there's a huge need to have these systems really integrated into the community, and that's especially critical when you think about the heterogeneity in cultures and customs and traditional practices across the continent. You build a big, flashy sort of emergency care system, with white coats, stethoscopes, ambulances. This may not be well received by the population, and then you have a real problem where build it and they will not come. Unlike the U.S., where pretty guaranteed you build an ER and expand it, will fill up pretty quickly. So I think that requires special attention. This has been a huge challenge in the emergency obstetric literature, trying to convince women, and traditional birth attendants, how you're going to sort of, move the cases more into a more sort of guarded and protected setting. So this I think is a very delicate issue of having the community engaged before you build these, and I don't want to say westernized systems because that's not what we're advocating, but build these healthcare facilities. And of course, they have to be locally appropriate. Yeah. So let's transition into the last two parts of the talk. And I'm going to very briefly describe a model that in part exists in the non-emergency sort of world, and we're now pushing this model for emergency care systems. So because we're having there are a lot of people who approach AFEM, champions from the Ministry of Health say, hey, we want to build an emergency care system in in city X or town Y. How do we do that? And so we're like, okay, here's a very, very simple-minded sort of basic template to run off. So again, we've published this, to try and spur advocacy. So the model looks something like this, and again, very, very basic. And it's a pyramid. The base of the pyramid is actually lies in the community, with first aid providers. Okay, because where do most emergencies occur, right? Out in the street, at homes. And then above that, a layer above that, is the sort of the transportation. So above that, let's see if I can do this. We have, transportation, and you don't see ambulance in here. It says taxi, truck drivers, police, fire, people who respond, people who are out and about when these incidents occur. And then above that, we start talking about the clinic level, district hospital level, regional hospital level, all the way to your most specialized center. And with that comes emergency physicians. Down below that, you don't see really any emergency physicians. We're not advocating people train hundreds of emergency, physicians. That takes, years, decades. So really simply, the model looks like this. Okay, there's out-of-hospital or pre-hospital emergency care systems that integrate with in-hospital emergency care systems. And I spend a lot of my time thinking and working and advocating around tiers 1 and 2. So let's start by talking about sort of what, and tier 3, there are a lot of strata within that community healthcare centers. So for example, in Ghana right now, we have a really innovative program we've set up where EMTs are training community healthcare workers in basic recognition and stabilization of emergency cases, because hundreds of thousands of these guys are out in the communities meeting acutely ill patients and they don't know what to do. Sub-district hospitals, we talk about district hospitals, regional referral centers, so we'll talk about these in a little more detail. All right, so that's the model, very, very sort of simply depicted. So I like to think of myself as part of the solution. I think you all do too. Those are going to be sort of in med school and in research careers in public health. So let's start at tier 1, and then we'll work our way through. And what I'll do is I'll give you a sort of a smattering, of some of these sort of innovative approaches within each of these 3 tiers. To show what people are doing, and some of these are quite interesting. Some of these, were borrowed from Western settings and sort of adapted, if you will. But again, remember, the title of this talk is really sort of innovations and challenges. Over here, they may not seem innovative, but on the continent, they very much are innovative. In the context of everything else I've described. So, tier 1, community-based systems. So, why advocate for these at all? Right? It sounds crazy if I came here and I said, well, we must train everybody in the community to be excellent at first aid. Well, there's great data in Western and developed settings, for example, for out-of-hospital cardiac arrest. Right? Your chances of surviving VFib arrest are significantly improved if you have bystander CPR. So in sub-Saharan Africa, where the burden of disease is different, and there are limited EMS systems, and where there are EMS systems, they're completely overwhelmed. And it may take decades before governments and agencies can actually, provide these resources for their community. Furthermore, communities are very, very much geographically sort of isolated and dispersed, large continent. We know that basic pre-hospital interventions are effective. This is a picture of the African, as the Belgian Red Cross philanderers developed sort of an evidence-based, African evidence-based manual for first aid, and there's some decent evidence. We know that these interventions at the community level can actually be very cheap, they can be sustainable, they can be effective, and they can be very locally appropriate, because guess what? Their advocates, their champions are people in the communities. So here are just a few countries that have some, what I think are innovative community-based systems that I'll describe to you. Anybody, I'll buy you lunch if you can tell me what those countries are. All right.
Ghana, Nigeria, South Africa, Madagascar, Botswana. No, Zambia.
Anybody else? And Uganda. I forwarded that slide quickly so I don't have to buy him lunch. Yeah, very good. Let's focus on Ghana and Madagascar. I'll give you an example of an intervention that's sort of catching, sort of caught on like wildfire now, and it's being replicated in many other settings, in small scale, nonetheless. So, I told you before that taxi drivers, commercial vehicles, bystanders will respond to trauma. So Charlie Mock, sort of a very influential traumatologist from the University of Washington, who's spent a lot of time on the continent thinking about trauma care systems, and colleagues in the late 90s sort of thought of and piloted a taxi driver trauma care sort of system where they took, in one city in Ghana, in Kumasi, they took about over 300 unionized taxi drivers and taught them some basic skills in scene management, basic triage, universal precautions to protect themselves, how to extricate and move patients safely. Okay, what the basic steps to a primary survey. Don't rush to that, that impaled object. Make sure the airway and the breathing are fine, those sorts of things. Hemorrhage control, splinting, where to transport a patient to, okay? And it provided them with a first aid kit that they could sort of source and refill locally with, pieces of cloth and things they could use as a tourniquet if they needed to, okay? And bulky, clothing to use as to protect the C-spine, even though there isn't great data for C-spine protection. And then they measured their outcomes, and after 9 and I think 12 months, and the whole program was really cost effective. $3 to train each taxi driver. They found that after 9 months, knowledge skills retention were upward of 75%, and over 50%, when surveyed again, over 50% of the taxi drivers actually used the skills in the last 9 months. Yes. Now, one could ask, well, where's the mortality data? Well, outcome science is really difficult to do. But, I think nonetheless, sort of a promising pilot that obviously warrants further, testing and, and research. So let's talk about, yes.
Comment on that.
Yes.
So, if you look at the problems with maternal mortality, right? The problem is exactly the same. So mothers die because midwives, or not midwives, TBAs, traditional birth attendants, have 1 to 2 deliveries a year, which is about what your taxi driver would. And the reason that there are too many of them to train is not cost effective in maternal mortality. Exactly what he's saying, trying to move deliveries to facilities is precisely that. Yeah. It's not cost effective to do it.
Right.
If you have 1 per half a year.
Yeah.
Sounds good.
Sure.
But they have multiple skills, they're not just.
Yeah.
No, I know. But so what I'm saying is that the number of interventions, right? So it's 1 per 2 years, 50% in 9 months.
Sure.
So you don't have enough to develop skills to maintain them and so on. So it's not, that's why they moved away, maternal mortality from TBAs. They're going back to it, but
Got you. Sure. So what I didn't say in this was that the number of providers that they surveyed or they were able to catch after 9 months was like 60% of the initial trained cohort, and of those, 50 of those, 50% of those had actually used their skills. And actually, of those who had used their skills, they had used them. The mode was about four times in those 9 months. But we also know that trauma skills degrade around 6 to 9 month intervals. So I'm not saying this is but it's a nice idea, and it has some promising, features. And the communities love this because they feel empowered when you take this beyond taxi drivers. So just an idea of something innovative, an example of something innovative that's happened. Yeah. We'll talk about a slightly different model in Uganda and South Africa of a community-based intervention. So in South Africa, it's called, they call this the emergency first aid responders. And I'm actually, this is something that I'm sort of very intimately involved with. Also something that looks like a very promising model, and my involvement is actually to do outcomes-based science, to see what patient outcomes are. So in communities in Western Cape Province, so outside of Cape Town, communities were saying, look, we watched our loved ones, friends, die on the street, and we stand there watching them die from intentional injuries, and we don't know what to do. And EMS just cannot respond in time. Very, very common story. So the solution, the provincial government EMS system partnered with community-based organizations to train them. So they trained them in trauma and in other non-trauma sort of first aid approaches. So these folks could sort of respond. And then, most importantly, I think, they trained them to activate EMS. And a big issue with some of these communities is that they don't have there are no sort of street names. So EMS has a big problem if they suspect there's a lot of violence, if there's, there are gunfire or knife wounds, EMS is hesitant to go. And secondly, if EMS doesn't know where you are, well, they're definitely not going to show up. Right? There's no point. So now what you've done is you have a known contact in the community that can tell you what's going on, say the scene is safe, and can direct you there if you are an ambulance operator, for example. So at the very least, even if their first aid interventions are ineffective, at least there's now a link from the community to EMS to get these people the help they need, hopefully in a timely way. So we're looking into this some more. So actually so today, almost 3,000 of these folks have been trained in various communities outside of Cape Town. So this is not, Cape Town is not, a lot of people say, oh, Cape Town's not Africa. Right, it's very well resourced. But you drive, 10 kilometers outside of Cape Town, you are very much in some of the, the hardest places in Africa. So the model looks like this, and I won't go into detail, but essentially it's a model in which there's community sustainment and engagement, and they sort of train themselves with EMS, and EMS helps provide some sort of oversight and structure to the whole program. And here's some preliminary data on some responses. So they surveyed these folks, asked them, after a couple of months of being in the field, what did you see? What did you respond to? And so here's sort of a histogram of those choking, unconscious patients, patients in shock. We did bleeding control. There was a stabbing wound, and we did something. patient with a burn, gunshots, and so on. So it's clearly a lot going on. So where I got involved was I was like, well, so what are the outcomes? How do these patients do? Are they harming people in the field? And preliminary data doesn't suggest that. There's at least no harm done, which is good. So now we know we have also some preliminary data that suggests that EMS is now getting to these folks sooner. Okay, and we know that there's a bit of a mortality benefit to having sooner care, especially in trauma, for example. So one can infer that, well, maybe these guys are saving lives. So we have a grant in, and we have sort of a lot of research going on right now to try and figure out what the outcomes are like. Okay. So we'll transition now into tier 2 systems. And these are more formalized pre-hospital systems. And in some settings they involve bicycles, some settings they involve taxis and vouchers where pregnant women are given vouchers to skip the line and give to a taxi driver, and they'll take you to the hospital if you're having a complication or something happens. Okay? So these come in many different flavors. And then there's what we think of sort of very traditional pre-hospital services, which are EMS agencies, which are no doubt the most expensive, the most complicated, and so they sit at the sort of the tip of the pyramid, if you will, in terms of resources, but they're important. So what is the state of these pre-hospital cases? Well, we have no idea, and so because of that, we have a sort of a multi-institutional, multi-investigator study going on right now, where we're surveying folks from all over the continent to ask them, what do you have? What does it look like? How many people do you transport? What are the outcomes like? So I'm actually going to be presenting this at an African conference in Ethiopia in about 3 weeks. So some pretty exciting data so far. So I won't do the name game again, the country game again, but we know there are at least this many, formalized systems. Okay, so these are big sort of EMS systems that either a city or a province is providing for the population, not sort of a private contractual ambulance service, where they have 3 or 4 ambulances, you pay money to receive their services. Okay, so this is great. This is better than we had thought. So in Ghana, the National Ambulance Service was sort of formed in 2003 by the Ministry of Health as a result of a tragedy they had where there was a football, a soccer match in the stadium, and there was a bit of a stampede, and the gates were locked, and it was tragic, sort of senseless deaths. And subsequently, a lot of road traffic collisions, especially buses with multiple victims, and so government said, well, we need a trauma care responses. So again, going back to the initial point where trauma has been a wonderful poster child for the need for emergency care systems. So the National Ambulance Service in Ghana was built, and it's evolved over the last decade in actually a very sustainable way. And I've been very sort of intimately involved, especially around education and capacity building, and also some research. And so that's not unique to Ghana. The countries I showed you in the other slides also have these. South Africa has the most evolved, of all these systems. Also in the north of Ghana, there's a model that has been replicated in many other African settings that I think is really exciting. So you all know very well that the burden of disease from, obstetric, maternal deaths and even neonatal deaths is quite high, alarmingly high in many African countries. And quite a number of countries are still off track with regards to MDG 4 and 5. Ghana is no exception. And so, and remember I told you that there's an ambulance service that already exists in Ghana. Now granted, it's not large enough to reach every corner of the population, but in one district, actually in 3 districts in the northern of Ghana, which is one of the most impoverished parts of the country, where ambulances just cannot survive the rugged terrain. The local, the deputy regional health minister said, we need our own solution. And we heard of this program that happened in Rwanda and Sierra Leone with great effect, with great results. Well, let's try it out in Ghana. And so there are a couple of companies around the world. This motorcycle over here is manufactured in China. It's called Motor King, and they sort of bring the chassis and the motor, and then you can fit it with whatever canopy or stretcher you want. So that way it just requires sort of local input, and it's done to suit the local needs. So in this case, there's a stretcher for a woman and an attendant of some sort, maybe a family member, maybe a healthcare provider. And they have actually about 20 or 30 of these ambulances. And when this program was introduced in 2012, sort of funded, I apologize, I don't remember the specific statistics, but the most recent update we've got is that the maternal mortality in that region has fallen about 33%, and there has not been any other significant intervention. And when they dig, sort of dig down in between the weeds, it's because of this program. So these ambulances or these motorcycles are, responding to people at home who, have certain complications and can't walk or hail a taxi to get to a facility. And they're also responding to facilities where these women show up and have complications and require higher levels of care. The people who staff these are community members with cell phones. Sometimes they don't have enough money to, fill their cell phones. And so, they use a text messaging system. It's free to receive text messages, unlike in the US. Yeah, right? So there's a system where one person at least has, somebody at a referral center, the hospital, has, a list of all these providers, who's on, the drivers and who's around, and messages them. And so they respond, and they respond well. And they take a huge source of pride from doing this for their communities. And guess what? This program is now spilling over into responding to trauma, cardiac issues, and other sort of acute and emergency conditions when they're not. But the priority is always emergency obstetric cases. In South Africa, in several provinces, but I think the best data comes from Mould-Millman province, their emergency obstetric ambulance program, now this is a more sophisticated program. So what they do is, at any given point of the day, X number of vehicles are earmarked for emergency obstetric cases. That's their priority. If you have a heart attack and you call and a call comes in simultaneously for an emergency obstetric case, you're out of luck if you have a heart attack. I actually think that is completely appropriate because the survival of folks with heart attack is abysmally low. Right? And the burden of disease is incredibly high. And there are very simple interventions, magnesium, delivery, pressure, and so on, for women who have obstetric complications. So nonetheless, these folks respond. And in Mpumalanga province, and I think in KwaZulu-Natal as well, they reduced their complications and deaths, the maternal mortality rate, by over 50% in 2 years. So these are, concepts like this, I think, are excellent sort of champions, for the need for pre-hospital care. And what I like about these models is then they start spilling over into taking care of trauma and other sort of emergency conditions in the community. Yeah. Now, it may not see it's when I say that, you're probably like, well, duh, yeah, why not, pick up the, well, but you have to prioritize this. This takes champions in the healthcare system to say this is important and we need to do this. I'll skip this. I think I'm going backwards. Any questions? So let's transition. Wait, that's
that tuk-tuk mobile or tuk-tuk ambulance, that's really what is needed. How do you, so that's on a project basis, is it over there?
Mm-hmm.
So how much does it cost and who's paying for it?
Yeah, sure.
That was the big issue for maternal mortality reduction.
Yeah, so this is about $1,500 to $2,000. By comparison,
motorcycle or?
Yeah, the whole, yeah. And this has been funded by a grant. And so now the government is investing in these, and so they've sort of taken over the purchase of these vehicles, and they're committed to it.
And so they train the guys who do the people.
Yeah, they train them in communications, safe transportation, and sort of very basic things, they can do for comfort for their patients. But the guys who drive these are not medical personnel, of course.
So there are a lot of programs in Tanzania and other places where they have, for maternal mortality reduction, they've got insurance programs at the village level. And the big cost there was always transportation. But this would reduce the cost dramatically because it's just an auto-rickshaw. So do you know how much it costs on the average per kilometer?
No, I don't. And they're writing this up now, but I don't. Yeah. It's not very expensive. I mean, it's a motorcycle, compared to...
No, that's what I-
Yeah. So by comparison, one ambulance, is about $80,000. That's a cheap
And the
ambulance.
maintenance.
Yeah. So just the cost of the ambulance, right? So, 40 of these for every one ambulance. An ambulance can't even make it into those environments. So let me dash through the last part, which is facility-based care. So there have been many innovations around emergency nursing training, mid-level provider training, and then physician training. I strategically put those two above emergency physician training because, again, that's very untenable in many countries for decades to train a critical mass of emergency physicians. There have been a lot of very, I think, cool, and I'll call them east-west partnerships. I think many of you know about MEPI, for example, the Medical Education Partnership Initiative. There have been a lot of tools that have been developed to help in acute and emergency care centers. There's been a remodeling of institutional culture to make emergency medicine sort of more accepted and more prioritized. And then, of course, there have been improvements in trauma care. So I'll give you a few examples from across the continent. Back to Ghana again, where they're training nurses. So the way this happens is, so MEPI, so through the Fogarty Centers, International Centers, funding the University of Michigan to be in partnership with a university in Ghana. And, so the Michigan brings in some expert nurses, work with the local nurses, they develop this curriculum, and then they reach out to nurses from across the country. So every year they have about 20 to 30 nurses who take 2 weeks out. Their institutions sort of, they're like, yes, we forgive you, we give you the time, please go and get this training. So for 2 weeks, the institutions, with pay, excuse them to all congregate in the middle of the country and are trained. 2 weeks, a week in the class, a week in the accident emergency center to get some practical hands-on training. These are nurses who are already practicing, okay? And they're getting certificates and diplomas around emergency nursing. And then they're going out into their communities and they're becoming leaders in their emergency centers and advocating for emergency care and triage and right care of their patients. And they have some good data. So in Uganda, for example, they have a slightly different approach. So in Ghana, the government said, you know what, we don't want mid-level providers. We want physicians and we want nurses. Okay, fair enough. That's the cultural sort of the culture in Ghana. In Uganda, actually, the Ministry of Health was all into it. So in partnership with the University of Arizona, what they're doing is these folks, they're training mid-level providers, people who are already providing nurses, PAs, and they're training them in emergency care. So there's a larger cadre of these folks than there are physicians who want to do this. So guess what? So you have your emergency center now. You have 10 or 15 mid-level providers who know something about emergency care. So it's a sort of, I think it's a 1-year course. Good idea. Yeah. So what about emergency training? This is happening in several different settings, but in Tanzania, for example, UCSF through the Abbott Fund, is funded, and they actually graduated their first class of emergency physicians a year ago. Ghanaians graduated theirs about 2-3 years ago, and the South Africans have been training emergency physicians since, I think, 2006. And these folks are going out and being champions and advocating for more emergency training and funding and so on. So it's a movement that's sort of, it's rolling and it's gathering more interest. So what else has happened in the in-hospital setting? Well, there have been a lot of, again, innovations. Triage, I think, is catching on like wildfire. And it's wonderful because even though triage is a very sort of fairly simple thing you would think to implement, it changes the institutional culture and it sets a tone in the emergency. The first place these patients come in for acute care, it sets the tone about, we think you're, we think you're important enough that we want to take care of you. We want to see you as soon as you walk in, do vital signs, triage you to the right level of care, and begin your care expeditiously. Okay. You can train nurses to do triage using South African triage very well, and we've studied this, and it takes 2 years to 3 years to really get them for the idea to really sink in and for them to do it well. When they do, their compliance with triage is good. Critical care. So this is actually just an example of what the South Africa triage scale. There are other sort of triage scales. For example, the Ugandans developed the Kampala trauma scale, the Triage scale. That's been around for, I think, over a decade. This has been very well sort of validated. It continues to be validated in other settings. It was designed and derived in South Africa. Okay. There have been other very cool sort of research studies. This one looking at CPAP in pediatric patients, but very sort of a more basic version of CPAP, bubbling it through water and just using a high flow oxygen supply, improving outcomes with patients in respiratory distress. And there's a lot of other stuff going on. Some of you may know about the FEAST trial. I think that was in New England Journal in 2011. While that was non-emergency based, that was in a critical setting where they resuscitated pediatric patients, with IV fluid boluses. And guess what? They actually did worse. What? They did worse? Why? Well, it turns out that Africans are very different than Europeans and Americans, where these studies have been done in the past. Right? So these kids have baseline sort of worse anemia because of malaria, so they don't respond. There's a recent, actually just a few days ago, this was published in the critical care literature over here, from Lusaka in Zambia, where they did a very focused sort of sepsis protocol with fluids, intensive fluids up front in the study arm, and a control group, which is kind of got usual care. And guess what? They had to stop the trial early because the mortality was higher in the intervention arm. When they looked at why, they think it's because they were flooding their lungs and they had no access to ventilators. And I think these are excellent sort of reminders to us why we can't just extrapolate care from sort of other settings to African populations, why some of this research has to be done de novo. And maybe there's some transfer of knowledge back to us in the US about what we can learn from some of these studies. Anyway, so there's a lot of obviously very cool sort of in-hospital interventional science going on around emergency and acute care. Very exciting. So this is the African Handbook of Emergency Care. We authors from all over the continent and North America. There's a partnership. So I was partnered with a couple of different African authors as the editor of that section. We wrote these chapters. This book got compiled and is now getting distributed to all of Africa. So folks who don't have emergency care training but who work in acute care centers can at least have a reference. And it's for a very simple sort of one or two page. Here's what you do in the first 5 minutes for this presentation. Here's not what to do, and so on. Lots of exciting things going on, I think. So how do we measure the success of all these programs? From my perspective, I think having more sort of pre-hospital care systems and models would be a great barometer to say that, look, we're actually moving from theory to practice. Increase in training programs, and I strategically didn't say emergency medicine training programs, but any form of emergency care training programs, especially to nurses and mid-level providers. I think more partnerships. There's a lack of capacity in many African settings, to do this sort of training and development and research. Professional societies, I think, are really important. And of course, we need to closely research what we're doing to make sure it's not harming patients, evidenced by the two initial trials I described about IV fluid resuscitation being potentially harmful. I'm not saying it is, it's potentially harmful. More research needs to be done. Okay, and ultimately, I think the ultimate prize is to see a reduction in the mortality and the morbidity across African populations, specifically with those who have acute and emergency needs. So I think ultimately, these three tiers I've described to you, that the sum will in fact be larger than the function of the individual parts. The key word here is systems, right? There are a lot of parts of emergency care that are being performed all over different corners of Africa. But ultimately, for these to work best, they have to be integrated into some sort of sustainable, locally appropriate, effective, safe system. And so that's what we're going for. And I think the African Federation for Emergency Medicine has been an excellent champion and an advocate for helping. So with all that said, I will stop. I know it was a lot, and I'm happy to take any questions. Yes?
I'd like to talk about the back end. So it seems like as you develop more and better emergency care, part of the problem is there are not enough intensive care units, even in the major hospitals. And where there aren't enough beds. And where there aren't enough beds, there are not many ventilators. So it seems to me you're going to have a disconnect because X% of the patients who are seen with better triage and better care of the ED won't have the right place to go.
Agreed.
Because there's still not enough critical care beds or critical care expertise.
Agreed.
Phil Hopewell has kind of studied this in Africa.
Agreed.
So how do you solve that disconnect?
Yeah, so, and that's why I keep using the word system, right? So in tier 3 is the in-hospital system, and the emergency care in-hospital system actually starts from the emergency care setting all the way through the critical care setting and the inpatient setting. So throughput is a critical issue. And so folks who go in now, so a lot of U.S. institutions, for example, get invited to come, build emergency care centers or, develop emergency care centers with African counterparts. And what people are doing now is they're bringing folks in critical care and people who understand sort of operations and patient flow through the system to say, look, here are the bottlenecks, but without enough critical care beds, patients are just going to backlog in the ED, and things will delay and outcomes will be bad. So there's a definite recognition of that as a significant problem. So one solution has been, another reason South Africa triage scale I think is quite brilliant, is that the most acute patients get seen immediately, and what South Africa triage scale does is it sort of almost mandates that patients get physically divided into regions of acuity. So in many different hospitals I've been in, there's a red section for the most acute patients, and it is not designed like the emergency departments here, where the idea is you'll be in and out in a couple of hours. The idea is you're probably going to be there for 2, 3, 4 days, receiving continuous critical care. The observation unit in the emergency departments are inpatient settings. I mean, in fact, the patients stay there for days. So this is a big problem, and it's being addressed. And I think people are thinking about ways they can resolve it. So they have, in some observation units I've been in the emergency departments, the inpatient teams come down around and see the patients every day. They're essentially managing patients down there because there's nowhere else. Yeah.
So it seems to me you can't be training more emergency room personnel without also having more critical care people being trained.
Agreed. Yeah, it's a big system. It's all linked together.
So we looked at some of this. I know Phil well. He worked with Sandy and
Everybody else.
everyone else. But we looked at this many years ago for pediatrics in Mould-Millman Hospital.
When Sandy was doing IMI.
Correct. And so that time we looked at the whole issue of how do you manage this. But the first thing is, and that's why that transportation is probably a critical link. The first thing is that if you look at people who die, children who die, I don't know about adults, but I'm sure it's the same. Children who die, 50% of them die on the way to the hospital. So they firstly, by the time they recognize illness, they get the transportation, they move. By the time they get to the hospital, 50% of the children who die on the way to the hospital die in the hospital. The other 50% die, well, not 50%, another 25% die in the first 24 hours, meaning they come very late. So the ability to transport them, that was a very important thing throughout. The second thing is that the system, so when we looked at it in the log, and we did this in many countries, looking at pediatric care, it turns out that the problems are not the beds, the problems are not the presence or absence of ventilators. That's a whole different kettle of fish. The problem is really the systems. So when I was there in Malawi, and I spent 3 weeks just examining care throughout Uganda, it turns out that they have, 80% of the staff are there in the morning hours. In the evening and night, there's nobody. So a simple thing like that changes it. The interns were running to get blood at night because there was nobody else who could get blood. So instead of actually taking care of patients, the interns were running to the blood bank to get blood because the one person who could transport patients from the wards to was taking one patient at a time. So
it's kind of like Cook County when I was in med school.
Yeah,
still like that.
But that's so it's much more. A lot of it was systems problems. If they changed just the simple system, and I was just in touch with people at WHO who had just come back from Uganda doing a similar evaluation. Guess what? We made this report. I spoke to the Secretary of Health, we made a presentation to the Ministry of Health. They said, oh, we'll change all of this. Now, 15 years later, whenever, nothing has changed. So it's not just getting it's a problem. It's more complicated than we.
But again, I think so. Systems reconfiguration, using what you have to work for you, and I think changing culture. It has to start from somewhere, and at least from the few settings I've worked in, I see this happening. From year to year, where the intensivists, for example, and the surgeons they get more responsive. They start being more being better advocates and champions for issues around and extrapolating from the emergency care center. Yeah, these are big, big issues, and I think that the stone is rolling. There's been slow change, and we want to again see that magnified. Kristen.
So I'm sorry, we have to stop. I would love for you to ask your question, but our time in this room is quickly coming to a close.
Thank you, Molly. I didn't have to say it. This was just terrific.
Yeah, good, my pleasure.
I will say that Dr. Mould-Millman will be giving a second talk for our lecture series in November on Ebola, so we hope to see you all.
More to go.